Ladies and gentlemen, as we kick this off, without further ado, Elizabeth Johnson.
And I'm a pacer, so this is really tough to stand in one spot here. But we're gonna give it our best effort here. Yes. So I'm talking about healthcare contracts, and these are contracts with payers. There we go. It took me a minute to figure it out. I have to give some of my disclosures. Financially, I have relationships with Medico CX, as well as Off Parency Incorporated. I'm on a couple boards and committees. I do some things. How's that? First disclaimer, I am not a lawyer. Please don't ask me legal advice. Please don't ask me to give you a lawyer. Nothing. I have nothing to do with the legal side of things. The photos in here are pictures from contracts. One main point of contracts is confidentiality. So I'm being as confidential as I can be. There's no identifiers, nothing. There are some really terrible scans because that's how people store contracts. So they're turned, they're lopsided. Not my problem. So what we're going to do is we're going to cover 10 plus years of hard-earned knowledge in less than 60 minutes, right? I actually get about 40 with the way the times work. Keep in mind the perspective of this session as it relates to access and reimbursement with an emphasis on medical benefit medications. I live in the buy and bill world. That's where I'm kind of speaking from. We'll talk a little about fee schedules and what you can do realistically. Now, I know the first question somebody's going to ask me is, have you ever actually renegotiated a contract? The answer is yes. I didn't physically pick up the phone and talk to them, but I did prepare all the data to go into contract renegotiation. So that's where I'm going to come from with this. If there are no questions at the end, we are going to restart this presentation until somebody has a question. Deal? There's me in a really great photoshopped picture of myself. I am a licensed practical nurse. I'm a certified professional coder. I'm a prior authorization certified specialist. And I'm a board certified patient advocate. That's my alphabet soup when I try to spell it out. My day job is I'm the CEO of Medico CX, which is a physician purchasing organization. I'm the president and co-founder of NAMAPA, and I'm the co-CEO that I share with my dear friend Melissa of the Healthcare Advocate Summit. Acronyms. We're in healthcare. If there weren't acronyms, then this would not be an actual talk. So to save time, here are some of the acronyms we're going to go through, along with my question of why do we do everything in acronyms and there's no standardization. But story for another day. So MCO is our biggest managed care organization. Mention IPAs in here. HCP is a healthcare provider. Value-based payment versus value-based care, one and the same. Fee for service, and then a management contractor. So what is managed care contracting? Has anybody here, and I'm a show of hands kind of person, not a poll kind of person, has anybody here ever signed, applied, worked with, or done a contract with a payer? There we go. Okay. All right. This will be fun then. Measurement, negotiation, and implementation of a provider or providers' services to provide healthcare to a demographic of patients. Basically, you are a doctor in this zip code, and you're going to provide X service, right? Now, there's a whole database that goes into this, and a payer can say, hey, there's too many orthopedics in this area, but thanks for applying. So in short, this is the agreement that stands between them. There are pros and cons to this, right? Most times a doctor moves into a place and they're like, I'm going to sign with all the payers. That's not always a great thing to do. That may not work with your region. That may not work with other plans that you have. So you have to look at each individual payer and contract as its own unique thing. The pro of it is you increase your patient network, right? You can take more referrals. Doctors in your area can send you other patients. It opens up a wide variety of things. I'm team access. I think this is great. But business-wise and strategically, it may not be. Some have good rates, some do not. There are hidden fees and these additional requirements. So part of this, in prepping for this talk, I was reading through, I had over 100 contracts I'm looking at. And there are some wild requests of doctors. I'll show you some pictures of some, like you can't have more than an hour waiting time. You can't be booking out more than 30 days. How many doctors actually are paying attention to that? And more so, how many practice managers are? Common issues. I get this one all the time. I just signed it. What? You didn't read it? No, I just signed it. Aetna sent me a digital file with a little, e-sign thing on it. I signed it, sent it in. Please, 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 please don't do this. I think we all know that. Our lovely physicians might not. They're signed without proper understanding. Have you ever read something and you're like, I don't get this. I don't understand what it is. I did that this morning with some terms and services. They don't negotiate. They think I get what I get and I'm not going to throw a fit. You really should throw the fit. A lot of times there's no experienced staff or dedicated staff to this process. So once you get into this contract negotiation phase, having someone to call every single week to follow up on this is absolutely essential. So a lot of times your requested changes or your proposed terms get sent back and they just sit for weeks on end. Without that follow up, it'll fall through the cracks. The other one is you signed it. Maybe you did negotiate. Maybe you got a great, fantastic rate. You've got good terms. It comes back. You scan it into your computer or put it in a file folder, and it's never to be seen again. We're going to talk about how often you should be renegotiating these and looking at them. Fun fact, it's every year. So some of the contracts I pulled from hadn't been looked at since 1996. Just slightly outdated. And then poor communication to team members, right? I come from the world of biologics. My job is to make sure that a payer will reimburse for the drug I'm about to bill. I need access to payer contracts and fee schedules. For example, if I get a denied claim and they're asking me for my invoice, am I contracted to send that invoice? Some payers do, some payers don't. But without access to those, I don't know what I'm doing. So oftentimes these get, again, signed, sealed, and put away. Rev cycle operations do not have the proper access to contracts to understand what they're looking at. There's this nice little, kind of small, I'm sorry guys, piece that I pulled out from one of the contracts. And the interesting thing here is talking about what they're going to cover, but they, going back, can determine the value of something retroactively. I don't want somebody to change that. I want that in writing. Get it in writing, right? So let's go back to the basics. Negotiation can take 90 to 180 days. If you are trying to open the doors of a clinic, or if you are credentialing a new provider, or you have a new payer, 180 days is a really long time. Because what happens to your patients? You can't hold those claims. You can't see them and wait to file them. Some people do that in that 30-day range. But really, you could be waiting and having to defer those patients. So credentialing can take another 90 days. Then you've got finalization, can take a little bit. Then you have to onboard to their network, right? They have to load all your rates. And I'm sorry if anybody here from a payer, they're not always right the first time. And then re-credentialing any amendments that may happen after the effective date. Here's a really great snapshot. So the physicians that I work with, we pass this to everyone. Please record, date, and digitize your contracts. Put it on a spreadsheet. Make sure someone in your practice or facility has this. Scan them in, have them all nice and organized. Make sure in your file format, so you're putting the date that it expires so that you know what that looks like, or the last date you renegotiated. This is a great way to take a look at it really quick. I'm a huge Talladega Nights fan, so Ricky Bobby's always my patient or person. There are best practices. Identify who you're contracting with. And I'm not just talking like Blue Cross, right? Who are you contracting with? Are you working with a physician there? Are you working with a physician case manager? Who is it that's going to be leading you through these contract negotiations? Because that person matters. Not that you have to go to dinner with them and they're your best friend, but you at least need to know what their role is, who they report to, and what that structure looks like. Negotiate with the facts. You can't say that I'm going to hire 3 nurses, I'm going to be able to see 30 patients in a day, and this is going to work. It's not how it's going to go. You have to have facts, as in, I'm an allergist, I specialize in asthma, I do full pulmonary function testing on my patients. In the last 60 days, I've seen this many cases, and I've done this many moderate to severe asthma. I put this many patients on medications. Like, you have to paint a picture and tell a story in a data-proven, I've got all my, T's crossed, I's dotted kind of thing. Understand your organization's value, right? My value in my practice is that I not only buy and bill, I utilize specialty pharmacy, I have a specialty pharmacy, and I do patient financial navigation. That's a big case, right? We counsel each patient to make sure they understand their costs. Not every place does that. We provide same-day services. We're open late. We're open on Saturdays. Those are all things that explain something different about your organization. Spell out those details. Make sure it's very clear. Specify your payment terms, right? I like to get paid within 30 days. And we'll go through some more timing things here in a minute. But what do you want? Do you want payment in 60 days? Would you prefer payment in 45 days? They may not budge on it. Sorry. But if you're showing your value, worst thing to say is no. Ask what those terms are. Reporting. As a payer, they have all the data and statistics of your claims that go through. Ask for reporting two ways. You will provide from your side, but you would also like reporting from them. How fast are your claims getting paid? What is your average time on denials? What does AR look like on their end? Those are all things you can ask for. And then dispute resolution, you do want this part in writing. This is where I'm not a lawyer, but I'm going to tell you what you should ask your lawyer for. The dispute resolution and the arbitration clauses, you certainly want to have that spelled out very, very clearly. It's not very often you sue a payer, but if you have to, or this happened with a payer a couple of years ago for us, you want to make sure it is absolutely crystal clear what those steps are and who covers what. Your termination, maybe you don't want to take that payer anymore. Maybe you want to drop that. Some have year-long notices you have to give. Some have 180 days. And then renegotiation. They don't have the same major components. Again, if you've ever read it, you've got your regulatory, your physician responsibilities, licensing, credentialing, good standing, malpractice insurance, the what happens if it goes bad, how they can get rid of it or you get rid of it, and then payment. Utilization management. This is a really big component now. In older contracts that haven't been looked at, this probably doesn't exist in there, though it should, because I think we auth just about everything nowadays. They can be a super huge headache, especially for people like myself. But it's important to understand timeframes and determinations, especially on that expedited term, right? We can't just send an auth in and mark expedited every time because we get an answer in 24 hours. One, that's abuse of the system. Two, that backlogs it for people who actually need that. And three, they just stop answering, sadly. The key one in this one is you will agree to give utilization management access to your electronic medical records. So that doesn't seem like a big deal, right? We can just print out something and fax it over. No, in this specific contract, this gives them access to your EHR system where they can go in and pull it themselves if they need more patient records. I'm not agreeing to that. Well, the right way, that would help. Okay, medical necessity really does matter. So in your contracts, right, when you're talking about utilization management, the medical necessity part is super, super, super important, especially if you're going through the medical benefits to purchase drug. They, in this one, may retroactively deny payment for covered services furnished to the member. Okay? I get it. I checked your eligibility. You lost coverage, but I checked it that day and it is covered, right? Usually I have grounds to fight and they will pay for that because at the time they were eligible. This one says, nope, we'll go back and take it. This happens a lot in marketplace type plans if someone doesn't pay their bill. But if you checked eligibility, it's well documented, you usually can fight for coverage. Very rarely do I have to escalate to external appeals for that. But for this plan, I wouldn't be able to. Compared to another one, if you meet medical necessity, they will not retroactively deny payment for anything that's been authorized. So if you got coverage, you're safe. Reimbursement. I think that's like the hottest part of this. Everyone wants to get paid for the services, right? And if anyone has questions, I forgot to say this, sorry. You don't have to parking lot till the end. I'm a conversational type girl, so raise your hand, please.
We were saying back here talking about how on oncology was usually that on the side, biological side too, but we have a lot of people that will call us and they haven't looked at a contract in 10 years. 10 years never looked at a contract. Guys, we'll look at those a little more frequently than 10 years.
You're spoiling my presentation. I'll get there. Having whole conversations without us back there, huh? All right, so y'all, I'm not super buttoned up and tight about these things. Again, this is conversational for me. Rates or percentages typically listed in your appendix at the end of your contract. And my least favorite thing about that is it's cool, right? Like if you have a flat fee schedule and it's in Appendix A, you're like, cool, I see this code is this. But if you haven't looked at your contract since 1996, I guarantee you that's not your rate anymore. So what happens is these get filed away. Inexperienced team members who get a hold of a contract for the first time look through it, and maybe that's your person loading your fee schedules, or maybe that's your person who's running accounts receivable. They're going to have incorrect numbers. So Appendix A is cool at time of signature. Appendix A is not cool a year later. Yeah. Hey, Lynn.
We see some of our product prices change every quarter, and I personally have never looked at a pay or contract, but for one of our practices. But is it typical to have language in there that says reimbursement will float with changes in ASP?
I'll go through those. Yes, some contracts are like that. But your details of reimbursement or compensation should be listed in here. Again, I had to take out which payer this was, but they agree to pay the provider reimbursement set forth in that attachment. There is language in there that says payment period. The key in this entire thing is this like clean claims thing. We'll go into that. Some more examples from different contracts. This is all referring back to that Exhibit A. Cost share rates, so on and so forth. This one is interesting here because it brings in the percentage thing, right? Provider agrees to accept 100% of the current applicable Medicare payment methodology. So what happens oftentimes, Lynn, especially on the medication side, on those J codes, it is a percentage of Medicare. And with ASP fluctuating every quarter, you're at 100% or 105. I've seen up to 120%. Those are great, whoever has those. So yes, it does fluctuate with that. And there are commercial payers that will do the same thing. So please check them every single quarter because those can change. That applies to your CPT codes, not just your HCPCS and so on. So we listed different ways. Most commonly are percentage of bill charge, percentage of Medicare, and then that set fee. So what you have to be careful of is this percentage of Medicare and percentage of bill charge. So in my little allergy world that I'm in January of this year, we had a new drug come out. It's an unclassified code or unspecified code, however you call it. And when you check your contracts, it says anything that's unspecified. And I think that's next. Here we go. What they say is for the unspecified ones, they will cover a percentage of bill charges, right? 30%, up to 70% of bill charges. Most common mistake that happens, and this is on the contract side, but they'll put in, my drug cost me $1,000. But if they're only paying you 30% of the bill charge, you're not going to get paid for the cost of that drug. So you have to do a little bit of math. And every contract can be different. And if you're not on top of your reimbursement and fee schedules, you won't know who's charging what. And it's much easier to set your charge master to cover all of your contracts than have to change your charge master every single time you're billing a claim. So if you know Aetna gives you 70% of bill charges, Blue Cross gives you 30%, you need to set your charge master enough to capture that 70%. Best way to do it. But these unlisted codes, they can be really tricky. So in some, they say if it's not listed on Medicare, it's not covered, they're just not going to pay for it. This one here asks for invoices. This one here asks for invoices. So I fight tooth and nail on the invoice thing. We all the time, especially on the Medicare side, bill out an unclassified code or bill other things. They're like, hey, send me your invoice. I work really hard to negotiate discounts and group purchasing and all that stuff for my offices. The last thing I want to do is just print an invoice and send it in because then I'm getting paid all of those discounts that I worked for. So you have to be able to obtain an invoice that has the actual whack price of that drug because once you send in your invoice that's discounted, that's what they load as their reimbursement, and it affects everybody else. Again, language is important. This is that 30% of providers' bill charges for CPT and HCPCS codes, and that's of the Medicare allowable. So where no Medicare ASP exists, you have to get a pre-auth in this case, and it'll be reimbursed rate of 30% of bill charges. So that pre-auth component is super important in there. In the prior auth world, we're used to looking at a formulary or a medical policy and saying yes or no, we need a prior auth, right? Most of the time it stops there. Manufacturers, I love your hub services. I'm sorry, I'm going to say this, but you can only trust what they got from their rep. So you have to check your benefits yourself. And if someone says no prior auth required, typically we prior auth everything nowadays. Please ask the next 5 questions. Do I need a predetermination? Do I need a medical necessity review? Is there any sort of voluntary review that I can do? Will you hold my claim for review? And do you need medical records with claim submission? I ask all 5 questions every single time because I'm not going to get held up without something. And I do have that in a little question column tree if anybody ever wants it. So, clean claims. So, who are my coders in this room or billers? I have two? Oh, I have three. Okay. Make them squeaky. I mean, squeaky clean. If you do not know what goes on a CMS 1500 or a UB04, find yourself a friend. Learn every little piece on there. I make cheat sheets for all my practices. I take a CMS 1500 and I fill it out. And I have every little box highlighted with a different color, and I write it all down. This is what goes in 24A. This is what goes in 19. This is what goes here. Here's how units for a NDC code work. Everything is spelled out. Because if your claim is clean and goes through the first time, you're getting paid on time. And in the drug world, we have payment terms with our distributors. I would like to be able to order drug, give it, bill it, and get reimbursed all before, and do copay cards, all before I have to pay my bill. So if it's not clean, you just messed up your whole timeline. So a claim that has no defect, impropriety, lack of any required substantiating documentation. These are big words for 9 a.m. Encounter data must be complete with things such as the CPT, ICD-10. If you know a drug is only approved for certain ICD-10 codes, I'm going to use asthma, right? If it is severe asthma, J45.50, and you throw on J45.51, which is with exacerbation, that does not count. That is not a clean claim. That's not what that drug is approved for. So chances are it's coming back. The provider information, NPI numbers are confusing, I know. There's one for the practice, there's one for the provider, supervising, all this kind of stuff. Please put your right NPI number on there. Timely filing. So again, let's go back to this timeline, right? This contract's taking you 6 months to get, you're finally seeing patients, you're buying drug. At this point, we're probably a year in, honestly. But now you want to get paid on time. But maybe your claim wasn't clean. Maybe you have a new practice manager and the claim doesn't get out. All contracts have a timely filing section. Most typically, it is 90 days. So that is what I base everything on. Very rarely do I see a payer that's 30 days. And if I do, that's one of the things I'm negotiating. But 90 days is pretty standard. This one over here is wild, has 180 days. Like, that's pretty cool. Some government payers, I'm not going to name names, have a 13-month timely filing. And these payment terms, right? So let's do some payment terms math. How's that? It's so early for this, I'm sorry. All right, so they will approve or deny your clean claim within 30 days. They then have 30 days to pay that. So we're already at 60 days. So if you've got a 60-day payment term with your distributor, you're not going to make your payment in time. So that's why 90-day terms help on that side. But if they don't approve it, they put it into pending claims, and you have 30 days from there. So then you resubmit, you put your clean claim through round 2, but then they have 60 days after that, after you send it in, to then give you another answer. So really, a claim could take you sometimes 120 days, which that's a really long time. And for those that deal with copay assistance, right? Copay cards usually have 180 days retroactive. So that date of service is the kickoff of that. But if you wait until you get a fully adjudicated claim, you might miss your window for copay assistance. So my pro tip there is, even if your first claim comes back and it's denied or it needs something more, send that in to your manufacturers. Go ahead and get it in so they have record of date of service. So that if it does take you 120 days or more to get that claim fixed, they have record of that administration and your patient will still qualify. So my best worst case scenario, I don't think you can really have a best worst case scenario, but we're going to call it that. It can be 61 days after the patient's visit. Dispute resolution. Payment or determination is rendered that the provider does not agree with. There are contract-specific requirements for potential resolution. You have to know the difference between internal and external resolutions. The internal stays within that insurance company, that payer. External can go out to either another payer, or that's litigation. You're going out to a lawyer or so on. So this pre-arbitration dispute resolution procedure I mentioned earlier is super, super important. You want to know what those steps are and when you've exhausted those. And I'm not talking for necessarily like a claim denial, right? They have their own 5 steps and so on, and can go external from there. This is for if they didn't pay you right, that's not my fee schedule, you guys aren't getting it right. That's what this pre-arbitration dispute is. You follow all typical other resolution for claim denials, authorization denials, and so on. Coordination of benefits. Has anybody ever had to call and work with a patient to coordinate benefits before? Especially in like your Medicares, my spouse is employed, I still have their insurance kind of world. Yeah. This one is the goose chase that I love prior auth and I love getting stuff for patients, but like this is the ultimate for me. I can spend all day on this one. So you want to know what that procedure is for that payer, because whether they fall primary, secondary, whether you have to let them know what's going on, whether you have to drop a paper claim to them, all of this will be in this coordination of benefits. The cool part about this contract, and this doctor is super lucky, that if the primary denies, you can still send a denied EOB over to them and they will go ahead and pay their secondary. That's great. That's super nice. Oftentimes a secondary will not do that because the primary didn't pay it. They go ahead and deny. So there are some nice contracts out there in the world. Hi, Spencer. So say you want to move locations, right? Because that's what healthcare does now. We move locations all the time. Not really, but there may be something in your contract about that. You may have a certain radius because, especially if you're in a saturated market, such as a city or a popular suburb area, there may be too many doctors in that. So you have to let that payer know ahead of time, hey, I'm going to relocate my office, and they can say yes or no if they still want to work for you. Many times this doesn't happen. The physician moves practices, then lets the payer know they've moved. That puts the payer in a weird spot. They feel like that's an ultimatum. And so they're like, oh, well, I don't know. So you may get hung up claims unintentionally because they have addresses they have to check, but it can cause a problem. So your best bet is to, if you're moving practices, to submit a notification, especially over 20 miles for this one, for example, that you're moving. So they're well prepared and they can say whether there's going to be a delay or anything like that. Overpayment and payment disputes. I love overpayments because I'm like, oh, hey, thanks for that. Then I immediately have to tell my doctors is that's not yours. So we got to send that back. They're not happy when that happens. There's always a section on this, but there's never one that says underpayment. I've looked through enough contracts to make myself blue in the face. They can come after me for an overpayment, but what do I get to do? You underpaid me. That goes back to that payment dispute. But typically, there are notices that can be sent, and they're really, really particular on the finality of that, right? If you're going after them for underpayment and they come back and say, no, we didn't do that, that's it. You lose grounds. So you have to follow those steps very closely. And then other provider requirements, which are really strange. They can include things like patient satisfaction requirements, where they are allowed to send out surveys to patients. They're allowed to call patients. Training or education from the payer. Doctors love to go to Saturday trainings, let me tell you. Reporting requirements. They may require some time things, clean claims, things like that. And a patient to be seen within a set number of days. The set number of days things really applies mostly to hospitals or providers with hospital privileges. However, there are some that do apply to office waiting times, like I was saying earlier. So this one is limit office waiting time for appointment to 1 hour or less. All right, I used to work for an allergist that chronically ran 2 hours behind. Love him dearly. He's probably one of my most favorite doctors in the world, but it was just, that's what he did. And now I want to go back and look through all his contracts. I'm like, I bet there's something in there. But it's asking that you are entering into agreement with that payer to provide a service. They're asking you as part of your service, cut that time down. This is interesting to me. Members will have access to appointments during all normal office hours and will not be limited to appointments on certain days or certain hours. Does anybody see a physician, and we do this in allergy a lot, where you could only go on a certain day for medication or administration? So like we'll do a biologic day only. So by contract with this payer, that is not allowed. We are not supposed to be doing that. So you have to be able to, if you work with this payer, that patient that has that coverage should be able to come into your office anytime you have normal hours posted. Well, okay, the loophole there is normal hours for biologics patients, but that is segregating out the patient. So best practice would be in that case to say, this is part of my shot clinic. Here are my shot clinic hours. So that is normal posted times. Where this becomes a really big problem is, like, I only see Medicaid patients on Tuesdays. You cannot segregate it out by payer, right? Or I only see my Blue Cross patients on Fridays. Cannot do that. If your contract doesn't say it, but has everyone checked every contract they have, maybe you get away with it. But best practice is don't just schedule it out like that. Here are some other examples. Emergency services within 4 hours. I'd love to see someone answer in 4 hours. 48 hours request for urgent, and kind of goes further and further. Renewal terms and amendments. All right, getting to the good stuff here. I'm still good on time, right, Jordan? Okay. Amendments can be submitted at any time unless specified. There's nothing in a contract that says you can't ask for more whenever you want to. Amendments can be made whenever. But you must have data and information to support those changes. So, like we said earlier, you got to paint your picture. You got to have your data. You got to have your statistics. Got to have it all put together in this nice, beautiful packet presentation. If you're not skilled in PowerPoint, find yourself someone who is and make it look real nice. An example of this agreement may be amended by mutual agreement of the parties as evidenced in writing by the signed parties. There's no date in there. There's no nothing. Renewal terms, they're usually listed in there. Typically 1 to 3 year. They're usually evergreen contracts, right? So they'll say this is in effect today for 1 year, renewing every year annually after that. So every year you have a renegotiation point, regardless of any amendments you want to make. What is negotiation? Nothing without data. So you should have done this before signing anything, but there's a chance after at your renewal. Best practices review and renegotiate. And use the data. So these are typical data points that I've pulled together for this, right? Your top 20, at least, if you want to be an overachiever, go up to 50, but your top 20 CPT codes billed. So if you're a practice that does not utilize medication, right, you're just strictly billing CPTs, that's fine. Your office visits, any procedures that you do, have all those together. If you are a practice that does J-code, any other supplies, things like that, that's a separate list to make. So you should have 2 separate things. If you are from the pharmacy side, right, your top 20 drugs listed out, your top 20 supplies you ship out, things like that. Then the one you're concerned with, right? What are your top 20 ones that get the lowest reimbursement? So you're taking your best and you're taking your least, and you're making separate lists of those. And any cost associated with those, right? So pulmonary function testing for me. I have to buy a mouthpiece. I have to replace tubing. I have to buy little pincher things for the kids' noses. All of that has a cost associated. So if I'm making $9 a test, that's not going to cover the tubing. It's not going to cover the mouthpieces. So having the cost of that, and say it costs me X amount of dollars per test, really helps. So where to start? Create that proposal. Think about the business of healthcare. I'm not trying to steal that from AAPC. It really is a good line. Business of healthcare and how you execute to the highest standard, right? Doctors don't always go to business school. I love them dearly, but that business component is huge and understanding how that applies. And this is where that team aspect comes in, right? I love to help my physicians in this case. So things to consider: your region, your top codes, and what makes you different, right? Testing, location. Are you multilingual? That's important. Tech advanced, right? It's not everyone has an EHR system. There are still some on paper charts out there. But do you have other things in place that make your office more advanced, right? Do you have remote patient monitoring? Are you utilizing a dashboard for inhalers? We have that. That's what sets us above. Any special fellowship training, hospital privileges, so on and so forth. For me, this what would you ask for? I'm going to ask for everything. Now I'm going to paint this glorious picture that I can get patients in within 48 hours after hospital discharge. I will see patients on Saturdays if it's an emergency. I'm going to let all of that out. And I'm going to say, listen, my goal is patient access. Here's the ways I do that, and list that. Getting patient access plays a role. Do you have the capability of providing patients care in a manner that no one else does? It's the practice of healthcare. We're all kind of doing the same thing. I get that. But what sets you apart? And do you have a service that takes patient care to the next level? Financial navigation and counseling is huge right now. So there are 3 major payers out there right now that have just built their own advocacy departments. And they actually have a nurse advocate that you can call, and they will walk you through the process. I'm going to be blunt. They are paid for by the insurance company. So what do you think their scripts and all that say? Right. Like they're going to go with what's in their little notebook that's sitting on their desk or in their prompts that they're given. It's not a free, hey, here are your choices, right? That's the miss, I think, in healthcare. This is my opinion I'm stating, is that we don't have the right patient options out there, right? We get so funneled down that it's here's this, right? Patient choice is kind of going away. So what sets you apart, what takes your care to the next level, is you present your patient with options financially, medically. You spend that time, and this goes on to your physicians. It has to be well documented that you spend the time with your patients to have these discussions. If your only goal is a financially driven, I'm going to see 9 new patients in a day, it's not the right way to do it. You will never move the needle on a single contract. But if you can show where you've changed your schedule from 9 patients to 7 new patients a day, you've increased your face to face time with your patients by 10 minutes each to spend on that counseling portion, that's how you change a contract in your rates. I'll get off my soapbox now. Do you have a biologics coordinator that spends extra time on patient education in the office? Again, back to that education point. There's actually, in one of my slides, I may have pulled it, but there's a whole part on patient education, providing it in the office, and that being an additional service line they were reimbursing. That patient education component is huge, especially on our drugs that go home to patients. The one study that's not out there, and I am determined to either be the first or find someone who's going to be the first, is loss to fridge, right? Oh, it's okay. I was like, what did I do? So, five person in the room, I promise. Um, feel bad for it. That's great. So the patient education part, right? These at-home drugs, they get shipped to your house. You get a box that's supposed to last you a month, sometimes 9, or sometimes 3 months or 90 days at a time. How often do you remember to inject yourself at the right time, take it on the right schedule? So we have drug getting lost to fridge. But if we brought that back to the office, I'm not saying the drug, but the education component of it, really talk to our patients about the importance of time. This is the assistance that goes with it. Here's a nurse navigator from XYZ pharmaceutical company. Want to be better for the payer, right? They see that you're going to prevent this loss to fridge, this excess and waste of drug, but it's going into time, right? Just got to be able to prove it. The team, your team needs access to contracts, right? In many places they are filed away, never to see the light of day. And then your many staff members will benefit from this. So I used to work at a really large allergy group. And when I moved into a biologics role there, I was like, all right, where's the payer contracts? Nothing had been digitized, right? We had 133 providers in 24 states, and not a single contract was scanned in. That all changed. We got them scanned in. Going through them, they hadn't been renegotiated in a while. There wasn't anything. There were several contracts that had no mention of J-code drugs. So they all fall in that unlisted category until we renegotiate, right? So here I am, a lowly little peon in biologics at the time. This is 8 years ago. It's a little different now. Having to figure this out. That means rev cycle didn't have it. It means operations didn't have it. And my doctors certainly had no idea what was going on. So contracts aren't, yes, they're important. Yes, they're proprietary. Yes, there's really important info in them. However, we are a healthcare team. Having access to those is super, super, super important. And I think advocating for those in advocacy roles and other type roles, it's important to understand that and be able to see those.
So,
yeah.
Zach Coleman,
Hey, Zach, how's it going?
University of Utah. As one of those frontliners, there is an iron curtain to protect that confidentiality, and oftentimes we're faced with sending out questions that we know would be addressed in contracts, waiting for a formal answer to come back from people. Is there any way that you would suggest building relationships with the contracting groups in a large organization so that there could be a measure of transparency to the frontline staff looking for that?
Sure. So it probably has to do, one, with confidentiality, 2, with time, right? And they're not just going to blindly send a contract or just send it out to someone, especially in a larger system. So the first thing I would ask for is a guided view of the contracts. And I would say, hey, I really need to see what the terms are in this or how it's spelled out so I can help my patient. Can I come meet you? You pull it up and show it to me. And then I would say, hey, listen, this is great. Can we do this every other week for 30 minutes? And if I don't have a question, I won't bother you. but I'd like to have this availability, or once a month, whatever it is. But I don't want to say, play the help me card, wave the white flag kind of thing, but ask for direction and guidance and say, hey, can you show this to me? And then build that trust and rapport and kind of go from there. I get it, in a system it's a little bit harder because they keep that really, really protected. But if that goes unanswered, I'm petty. I'm gonna escalate. I'm gonna go to their boss's boss and be like, hey, I can't help the patient that's coming to your system without this info. I need this. But that's me.
We do in our system, and so you can request exactly that to go meet with somebody. Most of that schedule, whether it's service contracts, all that gets reviewed at least once a year, because everybody gets reviewed. The problem is it often stays up top of them, just like almost 20 people. And so people that really need it don't ever get it. So you actually have to keep say, hey, I know at some point during the year, these contracts come up for review. Include me on X, Y, and Z or A, B, and C ones and let you know. And that's generally the best way.
You get your contracts, don't you?
I can voice what needs to be in the contract.
Yeah, talk to Angie. Angie help you on that one. So again, I have to put this disclaimer slide. I make no guarantee that your rates are going to change. Payers are a beast, right? I'm always happy to talk through it and give you tips and suggestions. I can't get this changed for you tomorrow, but this is a process, and to get you started on that process is the way to go. So we can talk data points. I have lots of data relations on like what to pull, but again, always happy to go through that. So that was a lot of info in a very short amount of time. Questions, comments, concerns, anything. Again, I said if there's no questions, we're going through it again. Yes, Jennifer.
Contracting sound fun.
You're welcome. I love I love reading the contracts. Like I will spend an inordinate amount of time on them. Yes.
I've never seen a medical contract. I come from the pharmaceutical, but you shocked me when you said you can negotiate. It's true. And actually, there's a person to talk to.
Yes.
There's a portal. And each time, you're done.
So yes, you are entering into a contract with the payer. You are agreeing to provide services for their members. So yep. So the physician can negotiate. Now, does it happen perfectly? Do you get everything you ask for? No. There's some standardization in there. But yes, terms, arbitration clauses, rates can all be negotiated. On the pharmacy side, I mean, I'm down to try. They make no guarantees again, but yeah, I'd love to be. So I helped set up a specialty pharmacy a couple years ago, and we used it for medical benefit medications through the pharmacy, and we could negotiate on that side. Yeah, for medical.
I think because we deal with PBMs.
Yeah. That's a whole other topic we could go down. I would love that talk. Anybody else? Yeah.
How does that impact the patient? Does it have an impact on them?
So depending on what the payer does, it might. So if you move locations and that payer says that market is saturated or they don't continue that contract, that patient may not be able to see that doctor anymore. So yes, or they may fall out of network. Yeah. So there are you can have in network versus out of network. Yeah, go Angie.
So I'm with Jefferson Health in Philadelphia, and we played Monopoly these last couple of years. And in playing Monopoly, even though the hospitals merged, that's what the contracts merged. So some of the payers, whether it's at tier 1, tier 2, tier 3, patients were traditionally used to be in tier 1, and when they merged, now they're tier 3, and or where they have. And so knowing it ahead of time, you have to make sure you get that notice out to the patients. Say that, now your services are going to fall under that tier 3, which have like a lot of high deductibles, but it definitely, the merging for locations definitely can impact,
They can't do anything about that. Changes affect that period. Are they relocated, not relocated, but allocated to other doctors, or are you still stick with the same doctor?
You don't have a choice to go anywhere. Doctors never want your patients to go.
Unfortunately, so this is the access part is huge on this, right? Because what can happen is if that patient, if they fall out of the network with the patient, oftentimes they're sent a letter, hey, we're moving. The patient then either has to find one. Sometimes doctors will say, here are the other places you can go. They don't want to lose their patients, but they also can't expect them to come pay out of network prices. So it is a point of contention in that. And so my recommendation to any physician or office considering moving, infusion center, whatever it is, if you're considering moving, you have to pull your payer contracts, pull your patient data, and look at who may or may not be impacted. So this should be something, it's not just about your building anymore. Granted, there are emergency situations and the real estate market is wild, but you need to consider all of these things before you choose to move. So it's not just as simple as like, I want to move my practice down the street. I like building 205 better than building, 150. There could be implications to that. Okay. Saran, you had a question? Yes.
Here, someone was surprised when the manufacturer got the call. I got underpaid, I'm not sure why. And it was just eye-opening and such a great resource to be able to say, have you taken a look at your contract? Have you taken a look at yours? So just a comment that this is a great refresher, even for those that are in manufacturing, pharmacy, and so forth, because usually it's that internal contract versus manufacturer reimbursement.
So I selfishly built this presentation kind of for myself. Sorry, guys. I've been to a couple of conferences lately that has had a talk on contracting, and it was like how to ask for 60-day terms from a distributor. It was a different type of talk, and I was like, I want the meat and potatoes of what contracting is. So this was a great learning experience and a great refresher for myself to build this slide deck and to pour through all these contracts. I'm currently working with a couple physicians on theirs as well. So yeah, I did this for me. Thanks, guys.
Yeah.
Yes, Lynn.
Your reports.
Mhm.
Negotiating with your value. Is there a ballpark of what's a good rate of first time accepts or denials, or that you're really presenting something that is of value?
So what I would do is twofold in that. I would look at in the office practice, right? Do they have a designated scrubber who's going through and fixing those before going out? Do they have a designated biller, right? So how many clean claims are you fixing? So how many claims are you correcting, making clean, and then sending out, right? So in our offices, they track on a spreadsheet. They put a little like X for how many like per day they have. So sometimes they only correct 3 a day. Sometimes they correct 10 a day. So then anything above 50% of clean claim approval, so going through, is good. The reason I say 50%, like that's kind of big, is that when you are sending, especially in the J codes where we are, there's the payers have rules, so many get pulled for audit, right? So there may be on their side a 50% hold on any claim we send through, not because they're not clean, just because it's an automatic hold. So anything above 50% is satisfactory. If they're saying that you only have a 30% clean claim rate or 30% pass through the first time, and you have data to show that that's not true, there's a problem with them. And that's when I call that out.
The percent that they are.
Yeah. That is a payer itself internal policy that they set based on their codes. So payers can set internally any kind of metrics they want to track or do. So Texas, for example, right now has that new gold card rule that came out. And so on the authorization side, if you've had so many approved in the last 6 months, you get a free pass to not have to do authorizations with that payer for the next year. What's happening on the backside of that is they've set an arbitrary number. They won't tell us what it is of how many claims they're holding. And it's increased, right? So most of our claims now get held for either more documentation, so we're sending chart notes, or just to review. So they're falling well without or above that 30-day payment. Sorry, Texas.
Yeah.
So that's internal, and payers won't necessarily cough up that info or what that is because it can change. It's kind of whatever they're looking at that time. But if you've got a really good provider rep So like Aetna got rid of all their provider reps. Sorry, you can't call them for this. But if you got a really good provider rep or contact there, which on that spreadsheet, list your contact, their email, their cell phone or direct number. You can ask them, is there something you're looking at right now? Are there, is there anything with this code specifically? And they can shed some insight.
50% clean for the time sounds low to me.
It sounds low. Sounds low, but if they're having a 50% pass through of clean claims from your end, that's great. That means they're going through, you're getting payment usually within 7 to 14 days. Yeah, I'd love it to be like 90, but I don't work on that side. Yes.
As an independent patient advocate, we do spend a lot of time on the medication education, medication errors that send our clients back to the hospital.
Yep.
So I can back you up on, some things probably from that end that could be improved that would help prevent.
I got 5 minutes, so I'm going to get back on my soapbox here. So I got 5 more minutes. I'm going to keep going with this. So on the independent advocate side, yes. And so I get that right now insurance obviously doesn't cover that service. With insurance comes rules. But the one thing that I think is missing in this healthcare spectrum is having the independent advocate working with a patient work with that provider's office. That could be a dual education component that really protects the patient. And so I think that we get into this blame game of whose job was it supposed to be. We all take care of patients. It's all of our jobs. So yes, putting more responsibility on all parties, I think could drastically improve that.
I mean, you could have two doctors for that client. So
Certainly.
prescribing medications.
Yeah.
Good service.
Oh yeah, I'm with you on that. Yes.
You brought up a really good point about loss of bridge and trying to avoid that through patient education, those teaching training sessions. And I'm actually curious, in your experience, have you seen with those types of those nurse educator programs, have you seen an impact one way or another, pros, cons one way or another, from a contracting standpoint on the venue in which those are delivered? As you mentioned, pulling them in office versus from personal experience, we ran one of those programs. It was field-based educators, and kind of the trade-off of staffing and time in the office. And also, I know there's a kind of a compliance and be careful around that for another session. But have you seen that impact contracting in any way, where and how those sessions are delivered?
So I've seen it in a positive way for the office side versus a third party. So a lot of times the patients, because they build rapport at the physician's office, they tend to default back towards the office or that person versus a third party, which if you have a great educator in your office that says, hey, this is your new best friend, and they help bridge that, it goes a lot better. But I have seen success from a payer contracting side where it was well documented that the patient spent 15 minutes with a nurse for education on how to inject, how often to inject. And the time component of documenting all that is a lot. Build a template, guys, to help with that. But I have seen positive success with that. Have I measured patient outcomes with it? Beyond a survey, no, I have not. Could make a great poster or white paper if we did. But yes, I have seen positive things come from that. Where I've seen some struggle happen is with the nurse navigators, right? There's the compliance side. This is all I can say. Please call your provider office. And the patient feels like they're in limbo, juggling between two. So that's really the only downside that I've seen on those. But great question. All right. I'm gonna let everybody go 2 minutes early. Jordan Johnson's after me, so you can stay in for his on value-based care, or feel free to roam to one of the other rooms. Thank y'all.